Alright, let's talk about pregestational diabetes. Affects 2% of all pregnancies. Hispanics have the greatest increase in type 2 diabetes in the recent years. How do you diagnose diabetes? A1C of 6.5 or more, a fasting of 126, or a 2-hour 75-gram glucose tolerance test of 200 or more. Management of diabetes during pregnancy. Insulin has the greatest resistance in the third trimester due to different placental hormones such as human placental lactogen, progesterone, prolactin, placental growth hormone, cortisol, TNF alpha, and leptin. Cortisol. Complications of hyperglycemia can cause spontaneous abortions, fetal malformation, fetal macrosomia, and fetal death. These patients needs to be seen every 1 to 2 weeks in the first 2 trimesters to check their sugar locks, and after 28 weeks it should be weekly. 300 kilocalories increase in pregnancy with singleton. In a normal weight person, usually recommend 30 kilocalories per kilo per day, with 40% complex carbohydrates and 30% protein and 30% fat. Insulin requirement increased markedly in the period between 28 to 32 weeks. In the first trimester, we usually use 0.8 units per kilo of insulin. In the second trimester is 1 unit, and then in the third trimester is 1.2 units. Fasting glucose should be 95 milligrams per deciliter. 1 hour postprandial should be 140, and nighttime should not go below 60 milligrams per deciliter. Lispro should be given immediately before eating, while regular insulin should be given 30 minutes prior to eating. Lispro is Humalog and is fast acting, onset of action 15 minutes with a peak at 2 hours and duration of 4 hours. Lispro and aspart should be used instead of regular insulin because of the fast acting. And NPH given before breakfast with Lispro and before evening meals or at bedtime. Onset of action for NPH is 2 hours, peak 6 hours, and duration of 12 hours. Continuous glucose monitoring shows less likely to experience neonatal hypoglycemia with less LGA and less admission to the NICU. Hemoglobin A1C value of 8 reflects a mean glucose level of 180 milligrams per deciliter, with each 1% higher or lower than 8 equal to a change of 30 milligrams per deciliter. Because of risk of DKA, patients should check urine ketone when the glucose level exceeds 200. Milk is preferred over fruit juice containing high level of sugar. 15 grams of carbs can be consumed and wait for 15 minutes for glucose level to correct. Glucagon for severe hypoglycemia and loss of consciousness. Maternal morbidity for pregestational diabetes. There is diabetic retinopathy, diabetic nephropathy, chronic hypertension, pregestational diabetes with is a risk factor for acute MI. Number 5, gastroparesis due to autonomic neuropathy, a risk for hyperemesis. And then number 6 would be risk of ketoacidosis. So for diabetic retinopathy, it is a leading cause of blindness between the age of 24 to 65. 1/3 of pregnant women with type 2 diabetes have retinopathy. The institution of strict glycemic control in women with diabetes and hypertensive disease during pregnancy has been associated with acute progression of retinopathy. Therefore, we need to have eye exams for these patients in the first trimester. Diabetic nephropathy affects 10% of diabetic pregnancies. It can progress to end-stage renal failure. If the serum creatinine is greater than 1.5 milligrams per deciliter, or the protein is greater than 3 grams per 24 hours. This patient also has high risk of developing hypertensive disease, uteroplacental insufficiency, and preterm labor. Pre-pregnancy baseline or early pregnancy serum creatinine and urine protein creatinine ratio should be attained. Regular checks of creatinine is recommended. So chronic hypertension is observed in 10% of pregestational diabetes. And then increased risk for MI during pregnancy, EKG, if the patient has signs of cardiovascular decompensation, risk of gastroparesis. These patients should use metoclopramide or Reglan, which can help with the autonomic neuropathy. Risk of ketoacidosis, 10% of pregestational diabetes. Risk factors, acute infections such as URI, flu, new onset diabetes, and insulin pump failure, use of beta mimetic tocolytics, antenatal steroids. Presentation, we'll have abdominal pain, nausea, vomiting, altered senses, arterial pH less than 7.3, low bicarb less than 15, high anion gap, hypokalemia. There could be fetal distress with minimal variability, but resolves when the ketoacidosis is resolved. We need to obtain arterial blood gases to document degree of acidosis. We measure the glucose hourly with also serum ketone and electrolytes. Treatment for ketoacidosis. We give normal saline 1 to 2 liters an hour for the first hour. 250 to 500 cc of normal saline for 8 hours, or half normal saline if elevated sodium. If glucose is 200 milligrams per deciliter, we can change to 5% dextrose with 1/2 normal saline at 200 milliliter per hour. After 8 hours, we use 1/2 normal saline at 125 milliliter per hour. If the potassium is less than 3.3, we'll need to hold insulin and give 20 milliequivalents of potassium to keep the potassium around 4.5. Insulin dose, loading dose 0.1 units per kilo, then continuous 0.1 units per kilo per hour. pH, if the pH is greater than 7, then no bicarb is needed, but if it's less than 7, then we have to give bicarb 200 milliliter of water with 10 milliequivalents of potassium chloride or more, depending on the acidity of the blood. Perinatal morbidity and mortality. Complication increase if the patient has diabetes for a longer time, or if the patient has concomitant hypertensive diseases. Major, so what are some of the perinatal morbidities? One will be major congenital anomalies, 2 preterm delivery, 3 stillbirth, 4 shoulder dystocia, 5 increased cesarean rate, 6 elevated postprandial value relating to macrosomia, 7 preeclampsia. So for major congenital anomalies, it also occurs about 10% of pregestational diabetes patients. Hyperglycemia during organogenesis is the key factor for abnormal development. A1C of 10 is associated with 25% of fetal anomalies. Some of these anomalies include complex cardiac defects, anencephaly, spina bifida, skeletal malformations such as sacral agenesis. And in terms of shoulder dystocia, there is a double risk for shoulder dystocia. Preeclampsia is observed in 20% of type 1 diabetes with nephropathy, but if the patient has nephropathy, it's up to 50%. Neonatal consequences, we have profound hypoglycemia. Number 2, ARDS. Number 3, polycythemia. Number 4, organomegaly. Number 5, electrolyte disturbances. Number 6, hyperbilirubinemia. Number 7, long-term obesity and glucose intolerance and autism. Some of the OB complications: hypertensive disorder, uroplacental insufficiency, preterm birth, increased C-section rate, polyhydramnios, pre-conception counseling. So preconceptionally, we should have the patient be examined by an ophthalmologist. We should get a 24-hour urine protein collection, get their creatinine, EKG, TSH, and lipid panel. Aspirin should be started around 12 weeks to 28 weeks due to high risk for developing preeclampsia. Pharmacology. So for insulin pumps, they can be useful in patients who has not had good glycemic control. However, this should be done pre-pregnancy. Glyburide does not cross placenta. It's a sulfonylurea. It binds to the pancreatic beta cells and increase insulin secretion from the beta cells, and it increases sensitivity in the peripheral tissues, it can lead to neonatal hypoglycemia. Metformin is a biguanide. It inhibits hepatic gluconeogenesis, inhibits glucose absorption, stimulates glucose uptake in the peripheral tissue. However, it does pass the placenta. Oral glycemic agents are not first line due to lack of long-term safety data. However, short-term data do not show any adverse effects. Fetal assessment for pregestational diabetes. We should get a fetal echo. NST should be started at 32 weeks with twice weekly testing. Fetal growth should be done at 34 weeks. If delivering is less than 39 weeks, we can consider amnio for lung maturity. Increased insulin requirement for 5 days if given steroids for lung maturity. Well-controlled diabetes can go to well-controlled diabetes mellitus can go to delivery day, but not recommend going past. Umbilical Dopplers for growth restriction. Induction of labor in pregnancies with fetus with suspected macrosomia has not been found to reduce birth trauma and may increase cesarean delivery rate. Day of delivery, continuous fetal monitoring is recommended. Intermittent auscultation is not feasible. We need to hold the morning insulin dose. Hourly check sugar during active labor with adjustment to insulin to keep glucose less than 110 milligrams per deciliter. Switch to D5 if glucose is less than 70. We run at 125 cc's an hour. If greater than 100, we start insulin infusion at 1.25 units per hour. Delivery time, without vascular complications and well-controlled diabetes, we can deliver between 39 to 40 weeks. Poorly controlled or vascular complications should be between 36 and 38 weeks. If baby is greater than 4,500 grams, can consider prophylactic C-section. Morning dose of insulin is withheld or reduced. Insulin drip to maintain hourly glucose 70 to 100 during active labor. Postpartum, the insulin dose should be halved or reduced to 1/3 pre-delivery dose. Breastfeeding usually takes about 500 kilocalories additional for breastfeeding.